Welcome to today's speaker series. We have the privilege of hosting members from the incredible Paediatric and Oncology Palliative Care team at the Royal Hobart Hospital. We thank them sincerely for their time, insights, and for joining us today. We would like to take a moment to acknowledge the Palawa Pakana people as the original custodians of Lutruwita, Tasmania. At Palliative Care Tasmania, we acknowledge the Palawa people's deep connection to family and community, and their enduring strength and compassion in caring for the sick, dying, and grieving. I would also like to pay my deepest respect to their elders past and present, and extend that respect to any Aboriginal or Torres Strait Islander people who may be joining us today. Before I introduce our speakers, just some basic housekeeping. We will have about 15 minutes to 30 minutes at the end of the presentation for questions. So if you do have any questions, please just pop them in the QA function, which is just at the bottom of the screen. And once we begin the Q&A session, we'll get started on those questions that you've popped in there. So without further ado, it is my pleasure to welcome our speakers for today's session, Dr. Sherina MuBiru, Dr. Tom Walwyn, and Helen Starosta. I'll hand it over to each of them to introduce themselves and share a bit about their backgrounds before we dive into today's session.
Thanks, Luke. I'll introduce myself. I'm Sherina. I am essentially a paediatrician and a palliative care specialist, which combined makes me a paediatric palliative care specialist. And I'm newly based down in Hobart with the Tasmania Health Service southern arm of palliative care. So working in an adult palliative care team and building a very meaningful relationship with the Paediatric Oncology service so that my skill set, I hope, can contribute to a really high quality level of care for children going through a cancer journey. And over to you, Tom and Helen.
Okay. My name's Tom Walwyn. I'm the statewide pediatric, adolescent and young adult oncologist in Tasmania. I'm employed based at Royal Hobart Hospital, but I have scope across the whole state and have clinical service with Launceston and Burnie. And I'm also an honorary paediatric oncologist at the Royal Children's Hospital in Melbourne. So I'm very much connected up with that service. Although I did part of my specialist training in Tasmania 20 years ago, I've spent the last 15 years working as a paediatric oncologist at the Perth Children's Hospital over in Western Australia, and I've come here for a better climate and nicer weather, and also to return to the pragmatic roots that I am. So as part of my training, I've done quite a bit of interaction with palliative care, both as leading it and working with it, and including adult palliative care as part of my pre-specialist training.
Okay, I'm Helen Starosta and I'm the clinical nurse consultant. I've been in paediatrics since 1989 and currently in this role for nearly 20 years. And my role is a statewide basis, and it's facilitating care for children with cancer all around the state. And I have very strong links with the Children's Hospital in Melbourne, where I do also now have an honorary position, which really helps facilitate the communication as well and developing those links there.
Luke, do you want us to get started?
Yeah, if you'd like to share your screen and we can get going.
Okay, so we're here today to give you some interaction. Oh, sorry, I'll just press that and that should work for you. We are here to, we've got some slides prepared, and during this, we're going to get the slides to advance. We're going to give you a taste of what pediatric oncology is and the sort of cancers and cancer journeys that children have as an overall. We're also going to relate that, particularly in the context of the interaction and pediatric palliative care, some of the things that are hardest, both inherently with the the sort of things we do anywhere, but also some of the things that are particularly tricky in the Tasmanian context. Helen will then talk to particularly the care coordination element of this, and then we'll pass things on to Sherina. But at points during this, we'll interact with each other and check in and elaborate some of these opinions. So to start off with, cancer in children is not something that is very common. It's in Tasmania, we have approximately 15 to 20 new or relapse diagnoses in a 12-month period. But if you look at causes for death in children, once a child has survived the neonatal period after they're born and haven't had problems with infections or structural issues, and you don't die from trauma, so sort of accidents, cancer is actually the most common cause of death in childhood. And children get different types of cancer, and it's an entirely different context than it is often in adults. So what I thought I'd do is to give you a bit of an idea of the sort of things that happen, and then compare that with adults, and then move on into the idea of the sort of disease trajectories. So there are some significant differences in the sort of things that happen even across age groups. These are Australian data, and you can actually see that the most common time to get childhood cancer is in the preschool age group, and the most common single group are leukemias, so the turquoise bar on to the left-hand side, and then things move over and change over the course of time, so that things like lymphomas and carcinomas and sarcomas come in as people get older. And I'm a pediatrician who's subspecialized in oncology and children's cancer, rather than an oncologist who looks after children as well, for that reason, because they're very different things and they need different treatment. This is in contrast to adult data, where the most common things that will generally crop up are prostate cancer, breast cancer, melanoma, colorectal, lung cancer. And for children to get those, there's usually it's very unusual, and there's usually an inherited reason for them to be more likely to it. So we don't have a whole lot of crossover with our adult colleagues, and by their nature, the numbers are smaller. And childhood cancer in general has been in the majority a success story of international cooperation and research, and always trying for something better, or something that people don't really believe is possible. So you can see that in this figure from the left, in the 1950s, there were some things that had below a 20% overall survival, through to the 2000s and now 2020s, where some things are doing very well, but other things are doing much less well. But when a child gets cancer, that is inherently a fundamental threat to, particularly from a family point of view, and very definitely from a parental role point of view, it's a fundamental threat to existence in a way that it seems to be almost unmatched by other things in both people's expectation and in their imagination. The world that we live in, as in the pediatric oncology world, one of the greatest success stories is a thing called B acute lymphoblastic leukemia. We've got to, over time, as you can see in the figure from the right, where back in the 1960s and certainly in the 1950s, the management of this diagnosis was with painkillers, potentially some blood transfusions and steroids for bone pain, and it was considered morally reprehensible to offer the chance of an attempt at curative management. And that, through successive generations of clinical studies, has come to the state today where things go very differently. But you'll notice that we still, even in this field of hope, hard won, but hope, there are children who don't make it, despite all of the complexities of immunotherapy and cellular therapy and bone marrow transplants and all of these things. And the journey or the trajectory over this course, particularly if things don't work out, is prolonged, complicated, involves many, many, many clinicians, and is I suppose, the ultimately horrible roller coaster. And so I've said that the disease trajectories and management of hope in children's cancer care is a difficult thing. And I would label this as one of the first challenges that I will refer to, other than the obvious challenge of having a child with a life-threatening condition. The journey is never straight or obvious. Over my career now and all my colleagues' careers, we in the field have had patients who we've seen through to adulthood, who we potentially meet their children or their ongoing life. We see the things they do in their life and who we didn't expect for that to happen. And that's an amazing source of joy. But we've also had patients who we all remember, and we accrue over our careers and the time where we thought things would work out, but they didn't. And what I thought I'd sort of do is to kind of give you a flavor of the sort of things and some of the factors that come in for some very rough and unofficial groups of patients. So the most common type of acute lymphoblastic leukemia patient would be somebody where we would be strongly planning for a long-term cure, and we would be openly talking about expecting successful therapy. And in this context, the success would be an adult who is visually indistinguishable from their peers in terms of fertility and vocations and many other things. And in these patients, there are well-established relapse therapies, but I've already alluded to the journey that can be complex, prolonged, and still not go the way we want. There are a number of other diagnoses, and in the Tasmanian context, these are often patients who have their care shared with Melbourne and have substantial times outside the state, where you go, the system goes into it with as much as they can possibly do, because we've really only got one shot to get this right. So in the context of relapse of these patients, we have very little or no proven relapse therapy with curative intent. That doesn't mean that it doesn't happen, but the trauma of this journey is more so. There are also patients who have, if you're doing statistics, and we actually generally try to avoid that because patients are integers rather than small percentages or bigger percentages, where we're very worried as to how things will work out. But all of us have got patients who've been long-term survivors. And when I said at the top of this slide, all of us are patients who are alive who we didn't expect to make it, these are some of those patients. But the conversation with the families and of the communication and what we're aiming for, so our goals, will be much more an upfront balance between the impact and severity of therapy and what we're trying to achieve. And I will allow conversations that people find scary and find difficult so that people have permission to think things that they're scared of. Again, some of these patients in the Tasmanian context spend a lot of time moving backwards and forwards between Tasmania and the Royal Children's Hospital in Melbourne for their care. We do, unfortunately, despite those curves that I showed a couple of few slides ago, still have diagnoses where we don't know something that will work for these diagnoses or these patients. That doesn't mean that we can't do things, and it's very important and very strongly pushed that we're choosing, but our choices of what we're choosing to do or aim for have to be more flexible, where we know what we hope for, but we also do things around the time now and the times that we have knowledge about. And some of the children that we look after are like this. And our interaction with people who are part of these conversations and are experts at taking this beyond a hospital setting are the palliative care and the pediatric palliative care staff as part of this team. In pediatric oncology, we're pediatricians and pediatric nurses first, as I've said, and then we kind of move into oncology, but we don't forget the context that we're working with, and this includes the fundamental holistic nature of family-centered care and care in the context of carers. We're used to and we expect to be involved to the end of the journey, whatever that or that is. And certainly for me and in the service here, there is very little dichotomy between curative and palliative care in terms of team support and team involvement. Very much beyond the end of things as well. One of the things I wanted to, I suppose, say, because even just preparing the last minute preparations for this talk, in terms of challenges, a child that has either no or very little hope for, or chance maybe, of cure or long-term disease control, we're very much part of an international community, and we use that without reserve for opinions and expertise to bolster, so that we are even that we're doing here what would be possible anywhere. Sometimes that involves travel, but families also often reach out for multiple of these opinions and for expertise, and we facilitate these, and because they always get better opinions when we're involved with those, but there is an inherent cost to these, particularly for opinions from the US, where some centers charge $5,000 to $10,000 for a second opinion. And there's also the concept of no stone unturned, and it's there's a strong need to be very open in the relationship and maintain a relationship with families, to walk a journey with them where the stones they wish to turn may not be either conventional ones or ones where we perceive or expect benefit after reaching out for opinions, and sometimes where we expect harm from those parts of the journey. And sometimes we need to hold that relationship in order to modify the course to allow best possible outcome, even if that outcome isn't curative. I'm now going to hand over to Helen to explain about the local care coordination and organization issues, particularly as pertains to this area.
So as Tom said, we coordinate all the care from Hobart, and we work with Launceston General to actually deliver chemotherapy and supportive care. In the northwest of the state, centred around Burnie Northwest Regional Hospital, patients can receive supportive care there as well. So it's basically the three main centres, and Tom and I work closely with the medical and nursing staff in those areas. When it comes to care here, approximately a third of patients will require care interstate, and that will either be shared care mostly, or they will have all of their actual treatment interstate. So particularly patients who have stage 4 neuroblastoma, which is quite a difficult disease to treat, those patients will virtually have all of their treatment there, although that may change. And if a patient requires radiotherapy, either palliative or curative, that will usually take place at the Peter MacCallum Cancer Centre in Melbourne. And so, but there's a lot of people aren't aware, especially some organisations nationally, that actually a good 2/3 of the kids can actually have all their treatment in Tasmania and do quite well. And that's been the case always with the support of the Children's Hospital for a very long time. So part of my main role is coordinating care. So as I said, I've been working in this role for 20 years and now have an honorary appointment, which really helps with the communication and also accessing my patients' notes in Melbourne, so I can actually see how well they're doing or not doing without being too intrusive, and keep it and see what needs to happen. So often the teams in Melbourne will talk to me directly, and then I will liaise with, for example, the staff in Burnie to say, well, this patient needs to come home to die. They've been told. Sometimes it's only a matter of days in between completely eliminating all the curative options that they may have been offered, to be told, well, we can't do anything more for you in Melbourne, we can arrange for you to go home. And that can, 24, 48 hours, we can have somebody back in Tasmania. And so part of that is helping the staff in Melbourne with coordinating perhaps air ambulance or other patient travel services to get them back. And often it's that linkage. A family may have only met the hospital briefly. They may have been, say, for example, gone to Northwest Regional, had the diagnosis and then flown directly to Melbourne. So they haven't got strong linkages with us. So it's about building up that link. So we generally get them in that situation to return back to Tasmania, to the hospital, so they can meet those people and then coordinate the care from there for their local services, like the local paediatrician and palliative care and the community health nurses that will go out and provide the care in the home. So it's very much, coordinating the role. And a lot of the time families have got no idea that I'm in the background doing all this work, which is as it should be. And then we, also as necessary, we might communicate with Tas Ambulance so that they're aware that, a patient may be dying, and sometimes families will make a decision they would rather return to hospital and their child dies there. And we have alerts so that the families can ring the ambulance service and the ambulance service react appropriately and sensitively to that child and family's needs. And that works well for the ambulance service as well, so that they're not put in a difficult position. So it's all about coordinating that care and doing those things that are possible. Thank you.
Thanks, Helen and Tom, for setting the scene. And coming now to children's palliative care as part of the care team for some of these children. So I like how you said, Tom, that you're a paediatrician. Helen, you're a paediatric nurse, that you've subspecialised in oncology. And I think that that's important to emphasise for palliative care. And I'm a paediatrician who's subspecialised in palliative care. And it's a specialty that's young, but it's born of need. And the way that we have found ourselves placed is as an extra layer of support, so that that notion, that gold standard of family-centred care, can continue when families are facing some of the most challenging circumstances they could ever have imagined. And it can allow care to transition across environments and locations, including into the home, which is so important when a child is living perhaps long-term through a treatment journey, or has more precious time, and to really still be able to foster their participation in their life. For palliative care, relationship building with a family is the first step, and it takes time to understand who their child is beyond the diagnosis. It's important, of course, for us to still share that expert knowledge that Tom and Helen hold about the child's particular cancer diagnosis and the impacts of treatment on their body, and as best as possible to think about prognosis. Although, as Tom alluded to, that's fraught with difficulty at times. But we want to look broadly then at the child in the context of their family and think about the supports they need across that time and across those different spaces. I think communication is at the heart of the work that palliative care does. We want to be communicating cohesively with the care team that we're partnering with, the paediatricians and the oncology services. And we want that care cohesively to then communicate messages that are consistent to the family. And if we're going to be conveying serious news, leaning on a relationship of trust that we've already established is essential. We can then also think about the emotional needs of the family and child in supporting them to cope through the grief that they often describe encountering at different points from diagnosis and through treatment, perhaps through until a child dies from a cancer diagnosis. In a helpful study I'll just mention from the Journal of Clinical Ethics, it's really important to note that what families said in that study was that quality metrics of care were valued most. So that was around healthcare practitioners providing compassion and emotional support and consistent care through a child's treatment journey when they had a life-limiting or life-threatening illness. Tom and Helen, you talked about a community of international health practitioners. We share that space, but I will just hone in on the local context. It's different across different parts of Australia, but here I'm part of a community which includes community health nurses, and they are absolutely essential to mention, acknowledge, and praise. Community health nurses are often nurses who do a broad amount of work across the age spectrum, but who step in when a child's time is precious and last days of care the family wish for those to unfold at home. And without community nurses, we wouldn't have that daily support to ensure a child's comfort, and the practical nursing needs of their care can continue seamlessly, we hope, from that beautiful hospital work through into the home environment. And some will be paediatric nurses, of course, I acknowledge. But being part of that community of health practitioners involves different specialties. Occupational therapists are absolutely vital to allow a child to flourish and realise their full potential within the time that their precious body and mind and spirit can sustain their life. And I think that occupational therapists just do a remarkable job at focusing on the living well for as long as possible and accommodating the different needs of each child through their cancer journey. And we still need their help to ensure comfort and connection for a child in their last days. And we also need the help of physiotherapists, very much social workers as well, and where they're available, child life therapists and spiritual care workers. All of us coming together look at these domains on this slide as being holistic care. And Tom and Helen's team are part of this circle of palliative care. It really is an ethos of care. And it says, okay, if we can't be certain of cure, then we are still going to hold your child's life as precious. We are going to strive to sustain and support them physically, emotionally, spiritually, culturally, and across the family and community context, so that they really do feel that their life has meaning and that they are able to take some of their time alongside the treatment journey of cancer care to still be living and developing and being a child, and for parents to be parents, for siblings to be siblings, to maybe go to school or hospital school, to win an award, to take a trip. So we can work as a community of health practitioners to ensure that if that child's life is precious, we are making the most of the care we can provide. It's care with a capital C, really, children's palliative care. We know these children might have a long illness journey, and so they're going to be a developing child throughout that. And we speak about trauma-informed care, but here's an opportunity for us to really apply that across our different roles, because there are particular traumas that are inevitable, whether it's receiving serious news or whether it's your experience of a long hospitalisation or particular procedural pieces in the care that cause fear. So we can think about a child's needs across those spaces, and then their developing brain throughout that, to optimise their ability to develop resilience and develop their own coping skills and develop their developmentally appropriate understanding of what they're experiencing, make sense of it all. We also want to really just say that in this space there's yes, a lot of expertise medically to lean into around symptom care, and whilst I haven't put studies here, there's a lot of work going on in the international community to improve the comfort of children with their pain, breathing distress, nausea, and that includes both medication options and non-medication options, which might include pediatric clinical hypnosis, visualization, cognitive behavioral therapy. We want to bring really what we can say is as much as possible evidence-based care that's tailored to the individual child and family's needs to improve their symptom control. And as a subspecialist, it's really important to speak to that there really is a specialty behind this to help care for these children. Okay, I'll go to the next slide, thanks. So I want to mention here really something that a colleague of mine, Gina Majid, a paediatric nurse in the top end, spoke to, which is the power of a cup of tea. I think about what it represents a lot, and taking a cup of tea with parents to just sit in the space of grief or hope or uncertainty, which can be really hard to hold, to sit with them there and reflect on who they are as parents, who their child is and what they've come through is such a privilege. And I hope shows to families that we want to take this time and show this care. And that's where in paediatric palliative care, a lot of work does take time, but families remember this. And it's so, so important to take this time. They remember and value this, and that is what brings the holistic care to the forefront. I think it's about the Maya Angelou quote, isn't it? It's that people might not remember exactly what you did or what you said, but they'll remember how you made them feel. And it's about saying you are safe no matter what you're facing. You're safe, and it won't always feel like this, how it feels right now, and you are moving through this. So really support and champion them as a family, holding together through this time, and sometimes through end of life and into bereavement. I think coming home is the other thing I want to mention here, and I don't know if Tom and Helen can speak to this, as I'm based in Tasmania only since the last 9 or 10 months, but coming home from hospital for care in last days is, for many families, really, really important on the cancer journey, and a time that my community of colleagues might partner with Tom and Helen to be able to help families have memories of an incredibly precious and sacred time, and to support them through. Tom and Helen, do you feel that's a space in the Tasmanian community of cancer care, children's cancer, that there is a need to really look at supporting?
I think we do, like all those services that you mentioned earlier, and the community nursing services in particular are very good and probably go above and beyond their normal time allowance to provide service. So I think we do reasonably well, although we've been fortunate, I think, in that we haven't had challenges of where children live incredibly remotely that might make things, more disadvantaged in terms of isolation. Yeah.
And I think maybe some feedback that some of those dedicated community nurses give me is that they want to do this work, but they do say, we really appreciate the support and planning ahead where possible. I do think a lot of our work in palliative care for children is planning ahead contingency plans for if A or B or C or D might happen, so that there's enough support for nurses to be going into the home and hopefully being able to attend to care efficiently and feeling safe and supported.
I think one of the things that I've found with families and, say, for example, the children who have been in Melbourne, often the timing, we get very little notice. So they may only have 48 hours before they've come back to Tasmania, and they may be on the ward for a day or two while we can get the plans in place. And then they've usually died within 2 weeks. So I suspect in the adult space it's a little bit more prolonged, but it can be quite fast in the paediatric space. So it's very much, we're trying to make those plans with a level of urgency to get them in place where we can.
Yeah. And I think that services try so hard to be responsive, whether it's, as you said, the ambulance services, community nurses, occupational therapists getting equipment into the home. If it's care for last days, I do really notice how services prioritise that for children, whether it's their core work or whether it's rare work for them. But I guess that our two teams can support them through, because it's not easy work when it's encountered less commonly. And I know sometimes my fantastic nursing colleagues will say in the adult sphere, I just don't want to do the wrong thing or say the wrong thing. So they really appreciate just having the opportunity to share ideas about what they might anticipate and what they can do if those things are encountered. And I guess it's all about upholding the value of that child as well when we plan ahead as much as possible, whether that's through formal paediatric advanced care plans or not. And even though we might never want to look at those last days and the piece around dying. When families do talk that through so bravely, I can feel that time still matters, how it looks. And so we can say, yes, your child matters even when they're dying, and we'll come and meet you where you're at. And if home is the right place, then as much as possible, we will try and make that a comfortable place for you all to spend that time together.
I mean, I think one of the things that you've talked to is the sort of pragmatic pulling together. I would say that, unfortunately, this situation inspires that in pretty much any service anywhere. But one of the things that certainly, and because I've only been back here since January too, Sherina and I were new arrivals, fairly similar timing, is that Tasmania seems to be good at pulling what it takes together to do the right thing for its families, partially because individually those situations don't come up enough to have systems that are standardly there to support them. So the state and its health services, certainly the people in its health services, are maybe more open to
rising to the occasion.
Yeah, rising to the occasion, or what in my old 1980s schooling approach would be the MacGyver approach, or things where you want to do something novel that's the right thing for a family in a situation. I'm glad to be here for that.
It's really positive. Finished on that slide, Tom.
Yeah.
I think this slide really, I just want to, demystify in one sentence children's palliative care. It very much is supporting quality of life, and it's about living well for as long as possible. So it's not to be necessarily feared as meaning the child is dying right now. What we hope is that we can reduce an experience of suffering in a child who's high risk of maybe physical or emotional suffering on a treatment journey. We hope that we can be mindful to value the preciousness of a child and plan ahead if they are high risk of dying. And I think that the way that our two services can work together in future, whilst there's been some really meaningful work, we'll probably come across some challenges as everywhere, and maybe we can work together to nut those out so that these children's needs continue to be supported in a way that's equitable, because I think that with palliative care, there's a trickle down. The adult palliative care specialty has existed for some time, and then it's sort of become known, okay, children have needs too. And now we're thinking about babies have needs too. And we're sort of a bit slower to apply that holistic and incredible teamwork to these children with life-limiting illnesses. So hopefully it's a space, though, that will continue to improve lives of children. So I don't know, Tom and Helen, to summarise whether there are key challenges being here longer than I have you feel you'd like to speak to. This was just a vision that I have put together for the future, and it's informed by colleagues and families in a different region, but I think it's got similar application here, including the vast distance, which you've alluded to, Helen. Accessible.
I think, you know, if you live in Western Australia, for example, it doesn't seem like it's a vast distance, but if you're 4 to 6 hours away from Hobart or Burnie or Launceston, and you have a regional area, the services are limited. However, we've been extraordinarily fortunate that we haven't actually had to face that challenge. I'd have to say we're quite lucky that most of our families live within at least an hour of one of the major hospitals. So we've been quite lucky, but getting access to OT, for example, sometimes that can be a bit of a challenge with things. But one of the things that we do try to do is that Launceston and Hobart do have a very small paediatric nursing team, and certainly often in Hobart, that team has been involved with the family at times. So sometimes they're also a little bit of a support to the community nurses. And certainly I've actually found even the school nurses can be really helpful when you have a child in a non-curative situation that is still going to school and requiring support in the school setting, and they have been really good. So that's another avenue of assistance that we have access to for the child that's going to school.
And I've alluded to the things, I think the inherent nature of pediatric oncology disease trajectories and navigation of those in terms of emphasis and goals, and when things can and should become overtly palliative, or when you're just being palliative in disguise, which actually we are a lot of the time all the way through that in terms of being goal-oriented. The desire to leave no stone unturned is very understandable, but making sure that that doesn't fundamentally get in the way of tasks and things that need to be said and need to be done in final times. And then I suppose, extending the Tasmanian specific things are particularly around persistently working with the interstate teams to share and work with us so that families come home and feel as immediately supported as they would with their team that they're often maybe more used to in Melbourne, for example, but there are other examples. And ideally with certainly clinical record systems that join up without us having to go to extraordinary lengths to seek information.
And I think one of the other issues, like we're quite lucky that we do in Tasmania have a statewide medical record, so that a local clinician in Burnie can actually see what's been happening if the patient, I try and put the documentation from Melbourne into those notes. But I think there's a bit of a disconnect for the GPs as well, because often they may have referred a patient into a hospital, and they do get some letters from the Children's Hospital in Melbourne, but they are very out of the loop often until they're back in the palliative care space. So it's about integrating them into that care as well.
I can see that there might be a few questions in the chat that Luke might want us to address, and so maybe I think if there aren't other sort of key future challenges we wanted to touch on, they might come up anyway in the questions. What do you think?
Yeah, I think we'll leave things on this slide for the minute and let Luke direct us to the Q&A session.
Yeah, brilliant. I'll just pop that back open so we can all have a quick look. But yes, thank you guys. That was really great. It was really informative. I'm sure we do have some questions in the chat. I'm just going to pull that up. So give me just a moment. Yes. So we've got some great questions. And if you do have any other questions that you'd like to ask, please pop them in the Q&A function, which can be found at the bottom of your screen. So first question. So from an anonymous attendee, but I am wondering if you have seen advanced care planning for children done well. What are the key elements for a young person? Is there a different approach?
Sherina, do you want to start?
Yeah, I'd love to. So the key thing to start with is to summarize it as being an understanding of values, goals, and wishes, and that it's not a legally binding document in children's care. So it's not the advanced care directive of the adults where we're saying, what level of intervention do you want us to take you to if your time is precious or a life-threatening illness is unfolding. So it's really exploring values, goals, and wishes. And what that does then lend itself to is, based on that, a conversation as the different stages of an illness unfolds. You're able to support parents to speak to the different level of intervention that might be pursued for their child at that time. So if, for example, a child is finding staying in hospital for a really long time very, very traumatizing, and it's more burdensome than beneficial if the time in hospital is not leading to, a long period out and cure, they might say, based on those values, I don't think another hospital admission of that nature in future would add value and quality time to my child's life. And so it gives them, I hope, the permission to realise they're coming from decision making as a parent with their child at the heart of things, and then we are sharing in the decision making. So it's not all on you, it's not all on us, but we'll share in that decision making. So yes, absolutely seen it done well, and it doesn't have to be all written down. It can be this kind of conversation, and it's just that it's not usually one. It's at often turning points. Is that often what you found, Tom? Like, there are turning points in the road, and then you need to sit and talk about, there's this pathway or this pathway. We need to talk about what's right for your child.
Yeah, I mean, they're always in best use, the focus for important conversations and for making sure that children and families are heard by clinicians and by the system in a way that's useful and constructive.
Brilliant.
One of the most impressive children's advanced care plans was without any identifying information, but a young person around the age of 13 who worked through about 4 sessions with myself and a paediatric nurse to talk about values, goals, and wishes through a tool called Voicing My Choices. And this was a young person in the out-of-home care system, and it was so important to him to have his voice heard. And so we were able to write down or transcribe, really, what his advanced care wishes were, whether things went well on his treatment journey, and just in case they didn't go to plan. And this young person was even able to say what was right for them, and there was a really important cultural and spiritual context, what was right for the care of their body after death, and to have some control over what would happen there in a life that had had loss of control through place of care and through the illness. That was really powerful.
Great. Thank you both. Question from Lauren. How are we supporting patients who are transitioning from pediatric care to the adult care system of care as they age out into the Tasmania health system?
Tom?
I mean, I suppose the one thing, I have to say, it hasn't come up practically while I've been here yet, but my remit clinically includes into an undefined point as a young adult. So certainly people who are at a transition age group certainly here now don't risk losing the clinician who knows them well and can help provide that continuity. And I hope to basically be able to do a similar job for the young adults that I look after, or particularly the older teenagers who become young adults during this journey, as I am able to do in the younger children. And it's particularly useful to have us work in a context of a whole health system rather than just a pediatric service, including Sherina's job across the pediatric and adult sector.
Thank you. A question here I've got from an anonymous attendee. It must be incredibly difficult work. How do you take care of yourself?
Helen, or
Yeah, we might go around the room. Maybe we'll just just a quick one from everyone.
I think for me, I have a personal philosophy in the work that I do, in that life is a journey, and the patient, I'm with them for their journey, no matter which it ends. And so for me, that helps me cope with the work day to day, and then making sure that I do have things that I enjoy. And currently I'm also finding moments of a glimmer each day. So looking at the fridge when it's lit up and gee, it's purple today, sort of thing. So just little things to, make sure that you're engaged, and having some really good colleagues so that you have those moments to debrief with your colleagues, which is really important.
Yeah, for me, I would very quickly say that a life outside your professional capacity and living that, and as much as with the passion that you work as well, is important. And that although a child dying per se is never something that I would choose, if that is the thing that is happening or is the way it's going, it is as important to do that well and to do that in a way that works for everyone as much as possible, as it is to have a different outcome. So it's no less satisfying.
Thanks, Tom.
And briefly, I would say respect and awe. I think it's respect for the incredibly resilient but also fragile nature of being a human being. And it's awe at the unique, precious, unrepeatable individual that I have the absolute privilege of meeting, especially if their time's short. The fact that I got to meet them is really a privilege.
It's a great perspective. Thanks, Sherina. And we've got one question here. I think this might be the last one from Rosalind. Any suggested ways of introducing families to the palliative care team? I guess in a way that doesn't signify the end of the road or a loss of hope. And also to Sherina, do you consider your role a 24/7 job? And how do you maintain balance in your own life, particularly when patients are nearing end of life at home, out of hours?
That's a great question.
I might start with this one and say that one of the reasons I talked about the trajectories was in part to allude to the points at which I personally think to either introduce, well, in this context, Sherina or the system, because I've done over time, and I think palliatively, first, you do have to. It's an intimidating thing to talk about a palliative care team, and it is. The introduction is usually best done after our immediate team are ready for some of those conversations and calling things. But for me, I spend quite a bit of time over many families explaining that palliative care is not end of life care, and that and also that it doesn't signify that I'm about to drop out of their system or we're about to drop off their system, and it doesn't signal abandonment by the team that they already know and rely on. It's an additional member of the team that can bring, at least initially, potentially other practical things around things like symptom control, and then can make, and yeah, it's an individual thing for individual families and patients, but those are some of the thoughts or methods that I've used in the past.
And I think I'll just comment that there are some incredible parent advocates for palliative care who've got lived experience. And as the understanding of the extra layer of support spreads, there are families who will reach out and ask for referral themselves. And I think that there is a growing understanding that it is not just about last days, and that there is real value and comfort in the extra support that can be provided when there's uncertainty. But I think Tom's really nailed it. It's knowing that we're part of the care team alongside Tom and Helen and the paediatrician. And I'll just really briefly say that this question's insightful because absolutely there's probably a risk for Tom and Helen as well that it's a 24/7 job. I think that the limited human resources in the peak specialty bit of the space to support the backbone of the families and the broader nursing community who are working with these kids, it does mean there's a risk of it becoming 24/7 and you know, running on empty. I have found some really lovely support in colleagues who will pick up with some of the plans I've made. So whether that's already Tom or a paediatrician who can certainly carry that work. So, and my hope for the future is that all of us are equipped with the sensitivity and skills to approach caring for a child, particularly at the in the last days, and not necessarily need to be a specialist for that piece. But that's going to be a growth in our education and training as doctors and nurses more broadly to see that unfold. So for now, we're all in this together. And so, yeah, I'm not alone.
Brilliant. Thank you, Sherina and Tom. That sort of concludes our Q&A session. So thank you again, Sherina, Tom and Helen, for your time in not just presenting today, but for taking the time to answer those questions. I know myself and everyone who attended today would really appreciate that. Just before we all depart, I'd just like to wish and extended a special thanks to our PCT members who are joining us today. If you enjoyed today's event, the best way you can support the continued work of Palliative Care Tasmania is to become a member. It's a really quick process. There's numerous member benefits such as receiving this recording. And if you'd like to become a member, you can scan the QR code or visit our website to find out more information. Thank you again for everyone who joined. Really appreciate your participation. And I know that you would have found today's session extremely valuable. To stay informed about our upcoming online and community events, please visit our website and you can find a list of all our future events that are coming up for the remainder of this year and into next year. We've also got some great resources on there as well. I also encourage everyone to complete our speaker series survey. You can do that by scanning the QR code, or you will receive a little link after today's session where you can provide some relevant feedback to not just PCT, but to our speakers as well. It helps us find and bring the speakers that our participants and stakeholders really want. So please take the 5 minutes to complete that. If you aren't already aware, our next speaker series will be held this Thursday, so 2 in 1 week, which is always nice. So on the 31st of October at 11 a.m, where we'll be joined by Peter Alford, who is the NUM, or the Nurse Unit Manager from the Specialist Palliative Care Service North team. You can register via our website or scan the QR code, which you see on the screen today. The last thing I just want to say is the nature of our topics we discuss can sometimes raise complex, powerful, and raw emotions. So I encourage you all to keep checking in with yourself today. Thank you all again, Sherina, Tom, and Helen. I know that you guys have an extremely busy schedule, so to grab you for an hour on a Tuesday is really amazing. So thank you again. I know that PCT and all the participants and whoever watches this after really greatly appreciate it. So thank you again.